Hello and welcome to Yodo, where we learn about difficult health topics in a less frightening environment. This channel is dedicated to considering the needs and concerns of patients with serious illness. If you want the closed captions on for this, just click the CC in the little white box near the bottom right of the video and they should start for you. A short red line will appear under the two letters and the closed captions should be on. I like that feature. I'm Dr. Sarabone, and today we're going to discuss cardiopulmonary resuscitation and consider circumstances when patients or their healthcare surrogate has made the choice not to accept this intervention, also known as a Do Not Resuscitate, DNR. As palliative physician, I am asked to help with difficult conversations. When there's bad news, there is no easy task for a physician to gently ask a patient that is suffering with symptoms what their reasonable healthcare goals include, or to discuss offered interventions and provide the likely outcomes for those interventions. It's really difficult for patients to hear, really difficult for families to hear, and really difficult for physicians to talk about. Most of the time, our palliative team needs to review and clarify the life-sustaining treatment choices, LST. When the situation is not going well and the circumstances have become bad, these options need to be reviewed. Patients are allowed to change their mind. In the process of patients making these decisions, we learn what they believe about the various life-sustaining treatment procedures. The LST for discussion today is cardiopulmonary resuscitation. I received a comment about an event that occurred March 2023 that received a lot of media attention, and you might have heard about it. 911 had been contacted by an employee of a senior living facility to notify them that a resident had collapsed and was barely breathing. The senior living resident was transported by EMS by the ambulance to the hospital where they died. Multiple investigations were triggered by the event as CPR was reported not to have been initiated at the facility. The family of the 87-year-old resident stated that they believed their loved one to have wanted a natural death, specifically not wanting CPR. This is an understandable and a reasonable choice. However, there was no community Do Not Resuscitate form on file at the facility, thus the ensuing controversy. Without a physician order for Do Not Resuscitate, CPR is the default. The question from the viewer was about declining CPR and the need for a DNR order. When an illness reaches advanced stage and the end of life is nearing, some patients do not want CPR administered. Conversations about bad news and discussing these choices are uncomfortable and emotion-filled. Patients and their loved one do not like to hear bad news, and like I said, physicians don't like to provide that bad news. But patients and physicians must be mindful and have these conversations and realize that even when cure is not possible, care is still possible, and there are lots of interventions that can be provided. Comfort-focused care is always available and often what many people in these settings would choose as end of life nears. Comfort-focused care means providing for every day to be the best day possible and to maintain as much function as possible with as few symptoms as possible. It is not about giving up or quitting. From a healthcare provider's viewpoint, we always care, and caring is even more important when cure is not possible. The patient has the right to learn all of the information about their illness, treatments, trajectory, and prognosis. They need this information to make the choices that are right for them. The conversations about interventions and possible outcomes demands time. Patients need additional time to consider the information and make the choices, choosing if the offered intervention is acceptable. Patients should make choices that are in line with their personal goals and priorities for quality of life and not out of fear. CPR is a procedure like any other, and for some, when all the information has been provided and reflected upon, they decide that the choice is to have a natural death and not to accept CPR. This requires a Do Not Resuscitate order to be placed by the physician in the patient's chart. The default is for CPR to be performed, and you will always get it if you do not opt out. Patients often consider many things when making their decision: their illness, what they have been through to get to this point, what lies ahead in the way of treatments, suffering, or symptoms that they might have had or that they might have, and their changing quality of life. They often discuss their age, life experiences, and their independence. A person's ability to do things and accomplish tasks is often a very important part of their decision-making process. They frequently ask what daily life might be like if they have a death event and are revived. What would their situation be like if they survive resuscitation? So let's look more closely at CPR, not just for the purpose of the procedure, but a little bit about the process too. For a bit of history, some forms of resuscitation date back as far as the mid-1500s with respiratory support. In the 1870s, it was learned that chest compressions could circulate the blood, but the idea and technique did not really gain much interest until the 1950s. By 1970, there was widespread enthusiasm for the use of chest compressions, and it soon became the default treatment. Everyone became aware of and has been offered to learn how to perform CPR. I first learned CPR in the 6th grade. Each of our household members was asked to learn CPR as my father was a heart patient. CPR initially was intended, and often successful, for situations when the cause of death of the person was due to an accidental cause or an unexpected death, such as electrocution or drowning. It was for use in people that were otherwise healthy. CPR was a sustaining bridge for patients to live long enough to receive a curative procedure. Restoring breathing after a drowning or hypothermia event are good examples. CPR supports circulation for a short time and can continue to provide oxygen to the brain and body. CPR by itself does not often restart the heart beating. Typically, electrical shock administration is needed to restart the heart. Thus, the appearance of automated external defibrillators in public places, schools, stores, libraries, and casinos, for example. There are a lot of circumstances and details required for CPR to be successful. Early identification of the person's death and immediate intervention have long been established as key to CPR success outside of the hospital setting. It is no different in the hospital. In the hospital, we certainly add many more tasks on the to-do list. Without these many things happening nearly simultaneously, the outcome is much less likely to be favorable. Our perception of CPR triumphs are skewed because of its presentation in the media. We like to be optimistic and hopeful, and we like to hear about success stories. Hollywood and TV shows play a big role in our perception of CPR success. The common beliefs derived about CPR survival based on media are not necessarily factual. Studies on these TV shows reveal that Hollywood often portrays a survival rate of 70%, with people typically recovering to full function and have all mental capacity by the end of the TV show. Unfortunately, reality does not demonstrate these bold outcome statistics. In 2018, a literature review of nearly 80 studies revealed that CPR survival has not changed significantly since 1980. Currently, CPR success with full recovery remains at a dismal 10%, and that's under witness circumstances. Remember when I said that CPR can bridge to a curative procedure? That procedure has to be medically possible, has to be available. Patients that have reached end-stage disease caused by one or multiple medical problems have already been receiving care for their serious illness, and many times they don't have a curative treatment available to them. Thus, for some, there is no treatment on the other side of that CPR bridge. CPR can be administered and even successful, but then the patient is just as sick as they were when the heart stopped. The healthcare system has many treatments available now that we did not have 10 or even 5 years ago. However, we have not found a way to turn back the hands of time. Also, there are diseases that cannot be cured at this point. What we are doing with treatment is to slow down the damage that the disease is causing. For patients that have reached the end stage of a chronic illness or have several conditions, or their health is complicated by advanced age, the chances of survival after CPR become less, and the chance for return to quality of life that the patient finds acceptable is often even lower. For hospitalized patients, that is folks with serious illness that have been so bad or so out of control that it's rendered the patient to need to be hospitalized, the statistics for this group are pretty bad. Less than 15% will survive CPR, and a smaller number are likely to survive to the time of hospital discharge. For some patients, they've become so ill that CPR may be required more than one time during a hospital stay. Studies also indicate that for survivors of CPR, their functional status is permanently adversely affected. Therefore, having insight into the patient's beliefs regarding quality of life is very important. A patient's views on quality of life can be based on many things, including independence, return of physical ability, and practical cognitive function. When a patient is faced with the decision, their immediate reaction might be to just do everything. And it's our responsibility to take time and ensure that patients or the healthcare surrogate is aware of what doing everything can mean and the probable outcomes of that. This information should factor into their decision. We don't ever want someone to say, "I didn't know," or "no one told me." We provide full disclosure as compassionately as we can about the procedure of CPR and the likely outcomes. These conversations deserve time, thought, and consideration by both parties. It requires honest, realistic, and open dialogue with back and forth communication between the patient and physician. Physicians concerned about a deteriorating patient condition may want to expedite the conversation. Some patients and families have never considered end of life and never discussed it. When these two situations occur in the same clinical setting, a deteriorating patient and the healthcare surrogate has not ever discussed the patient's belief system, our palliative team is often called. These are very complicated situations. We need to discuss that when CPR is successful, patients are not likely to return to their prior health state, and that may not have been very good. It is often a long uphill climb to return to better health, and for some, the insults have been too great and it's just not achievable. A few patients do return to their home, but for many, the next location after the hospital discharge includes possibly going to a rehab center or maybe going to a long-term nursing home situation. For some, the level of function they achieve is not a level of independence that they find acceptable. Many studies have shown a wide variety of emotions that the CPR survivor has. They can have happiness and relief and yet be torn between some unexpected emotions. The person can feel a sense of sadness over their loss of skill and function, anger about pain or bodily injuries. For others, they can have a complex mix of depression or even guilt, as they may perceive being judged by others for being ungrateful for their extension on life. It's a complicated weave of emotions for many survivors. Some people question, what's the harm of trying? Well, we do not do this procedure in a half-hearted way, just to try it to see if it'll work. To not have CPR, the patient must specify they do not want resuscitation, and there must be that DNR order in the chart, or we are all in. That means that we will depress the sternum 2 to 2.5 inches with each compression and have a goal of 100 to 120 times per minute. The compressions on the chest are hard and fast. Chest trauma is a common result of the process of CPR. Cracked or broken ribs, possibly a fractured sternum, maybe a lacerated liver or lung, and certainly the potential for severe internal bleeding. Now, I don't want to mislead you to think that the process of CPR is painful. CPR is only done on dead people. But if the procedure is successful, then these injuries and the subsequent pain will be experienced by the patient. Nearly 1/3 of CPR survivals will have subsequent neurologic disability as well. Patients with advanced age or advanced disease stage, cognitive impairment, bone fragility, cancer metastasis, end-stage heart or lung diseases, these patients all have very poor outcome statistics. We discuss these risks and possible outcomes when we have complex goals of care discussions and we review a patient's life-sustaining treatment choices. These decisions and discussions have to be individualized as the clinical scenarios vary widely. Sometimes patients will instruct us, if the doctor doesn't think there's a good chance for me to come back, then don't do CPR, but I would like for them to try at least once. It doesn't work that way. Occasionally, I have had patients tell me they would like CPR as seen on TV without the ventilator or tubes being applied. And that's not possible either. We can't coordinate those rapid, aggressive compressions with the necessary breaths given by a mask. Breaths must be given through the endotracheal tube to be successful. Every member of a code team is a highly trained, passionate individual, sort of like an in-hospital SWAT team. They have frequent tests and drills. The team responds to the code blue situation around the hospital, and they are committed to follow all established guidelines to provide the patient the highest possibility of a successful resuscitation. When a code blue in the hospital is announced, the code team responds immediately and enthusiastically. They do not have time to review or discuss possible outcomes with a healthcare surrogate. To be clear, if there is no physician order for Do Not Resuscitate in a patient's chart, CPR will be vigorously administered. And as far as CPR goes, in the words of Yoda, we do or do not. There is no try. Beliefs, articles, and choices are numerous on either side of the invisible line of CPR beliefs. And for survivors too, those that are pleased that they had the successful resuscitation and those that are not as happy with the outcome after surviving the resuscitation event. Learning from patients helps me become a better physician and better providing information to others. Patients have expressed to me many times over my career that they want to know the pros and cons of what the book says, but they also are interested in what others have experienced. CPR is no different. Most patients are interested in what the book says, but many also want to know real experiences of other people just like them, and I encourage the open dialogue. Back to our initial news event in question, it is great that this family knew what their loved one wanted and that they were at peace with her death. But it's not great that the community DNR form was not present and on file at that facility. Had the form been present, she could have been made comfortable and remained in her home setting at her community facility and not had to go to the hospital at the time of her death. When a patient with a life-limiting illness is considering CPR, they have many thoughts, and it's not only about life and death, it is also about understanding the outcome and likely quality of life if their heart is successfully restarted. For some, the outcomes data is not acceptable. Discussing openly the patient's viewpoints regarding what they define of quality of life is necessary. Patients are asked to consider their current health and what their situation might be like if they have a death event and are revived. For cancer patients, they would consider if they would want to continue with treatments. Do they feel strong enough? Do they remain confident that cure is possible with restoration of good health? If a patient has end-stage kidney disease, they might be thinking about restarting dialysis after a successful CPR event. For patients with end-stage cognitive impairment, the healthcare surrogate is the one who's doing the considering, and they might be thinking about if the heart restarts, the brain is likely to have suffered further damage during that process, and would my loved one want that, or would they prefer to have a natural death with comfort provided at the end of life? CPR does not cure end-stage disease, and if a patient has been experiencing suffering from symptoms such as pain, shortness of breath, fatigue, confusion, those symptoms are not going to be cured by CPR. There are always interventions that can be offered, and sometimes cure just is not one of them. Patients and families want to be offered reasonable choices to select from, and they want to have a treatment that they can be offered to say yes to. It is not ever acceptable for a physician to say there's nothing that can be done. If you're informed there's nothing more for you, demand to speak with your palliative team. These conversations with your loved one and healthcare team should be ongoing and should be documented. There are certainly times when a patient does not want CPR, and that's totally appropriate. Please sign the Do Not Resuscitate form. I appreciate your subscription and helping this community grow. It's brave for you to be open to learn about the icky, taboo subject of end of life. Thank you for being here and for providing me with your questions. I'm also grateful when you forward these videos to others that may benefit from this information. If you have a topic that you would like to learn more about, please leave a comment below. Bye now.